I'm excited for these next group of lectures. Again, as Glenn had pointed out yesterday, we take feedback very seriously, and these next couple of lectures were based on feedback from our audience in terms of things that they wanted to hear more about, learn more about, things that we haven't covered previously. And so the first talk this afternoon is by Dr. Pavan Tankha, and he's actually anesthesia trained. So he completed his anesthesiology residency at Cleveland Clinic, and then he did a fellowship in pain medicine at the Cleveland Clinic as well. And so he currently serves as the medical director for our Comprehensive Center for Pain Recovery. I share a lot of patients with him, and it's a wonderful resource that we have. And so we asked him to come speak with you all about his approach to pain management as it applies to our neurological patients. So without further ado, Dr. Tankha.
All right. Good afternoon, everyone. Again, I hope you are all caffeinated, as my monotone voice may put you all to sleep after lunch. So I have a lot to cover. There should be some time for questions at the end, and there's a question session at the end. The way I came up with some of these cases and pearls was based on what neurologists either at the clinic or out of state refer in. So I hope you find this useful. So a couple of different objectives. We're going to review the 3 types of pain, the biopsychosocial model of pain management, and then various presentations of common pain conditions you may see. So we're going to start off with a little bit of background. So quick thought experiment, and again, I apologize, everyone's postprandial and making you think, but in your training, at any point, specifically medical school or sometime early, do you remember learning about heart disease, right? I remember weeks, months of training about heart disease, cancer, diabetes. How many of you remember a similar amount of time learning about chronic pain? Did anyone have any official training in chronic pain? Wow, that's impressive. A little, okay. The reason I bring this up is chronic pain is the #1 reason patients present to medical providers, more so than diabetes, heart disease, and cancer combined. And without any training, we're essentially winging it when patients come to see us. This is important because if you read the JAMA editorial a couple months ago, the number of chronic pain patients is increasing dramatically. And the argument is we're not identifying treating chronic pain acutely well, and then it's transitioning over to chronic. So when we define pain, I think the best definition is the IASP definition, where pain is a sensory and emotional experience. Simply the physical sensation is nociception. Pain is the sensory and emotional component. Another thing that's very important is it can be with actual or potential tissue damage. So when we talk about the different types of pain, we have nociceptive pain, actual or threat damage to tissue, activation of nociceptors. This is classically seen in inflammatory types of pain, OA, etc. Then we have neuropathic pain, lesion disease of the somatosensory nervous system, postherpetic neuralgia, trigeminal neuralgia, sciatica. And then the third classification, which is relatively newer, is nociplastic pain. And this is altered nociception despite any clear evidence of neuropathic or nociceptive pain. And we'll talk about this in a few slides and define it a little bit better. These 3 types of pain aren't mutually exclusive. You can definitely have nociceptive pain, for instance, osteoarthritis with a nociplastic type of pain, such as fibromyalgia. They can coexist, but these are the 3 major types of pain we work with. And again, taking you back to your first year of medical training, I apologize, always unpleasant thinking about basic physiology, but our pain pathways. We have transduction, transmission, perception, and modulation. Modulation, also known as descending inhibition. And these are important to keep in mind. I trained as a pharmacologist, and we used to joke, pharmacology is nothing more than understanding a pathway and then drawing an X from one pathway to the next. And so when we talk about rational therapeutics or how we treat pain, understanding these pathways is very important. If for a second we superimpose our pain pathways over the IASP definition, so you see pain is a sensory and emotional experience, and then you have transmission, transduction, modulation, which is all the sensory components, and then perception is the emotional. And arguably, looking at it this way, the perception or emotional component is 50% of the pain experience. Last thought experiment, I promise. So you have a patient with cancer. And thankfully for the patient, it's amenable to surgery, chemo, and radiation. How many of you in this room would only offer the patient one treatment option? We're just going to try chemo and just cross our fingers. We're just going to do surgery and see what happens. Right? No one. That's absurd. Yet when we think about pain, that's essentially what we do. Most of us do, at least. Here's a medication. Here's an injection. Here's a surgery. It's very uncommon for us to ask about, well, is this causing any depression, anxiety, PTSD? Do you have a history of trauma? Many of us don't ask, but again, arguably, it's 50% of the pain experience. And so the question becomes, okay, if it's that important, how do we approach pain? And we approach pain through the biopsychosocial model, the biological, the psychological, and social aspects, understanding the person with the pain. Of note, one of my colleagues keeps saying, this is a new way of approaching pain. This has been around for 40 years. It's very well established. And so because most of us have not had an official pain curriculum, it may be new. If not, I'd love to review it briefly with you. So we're going to take the biological. When we talk about biomedical approaches to pain when patients come into the office, we have self-care, which I find incredibly important. Diet, activity, sleep. Oftentimes patients may roll their eyes. I've done this already, doc. What does this have to do with anything? And helping them understand diet, activity, sleep doesn't necessarily take your pain away, but when these are not well controlled, your pain can increase. And oftentimes pain takes control away from patients. This is one of the simplest ways they can gain some of that control back, by optimizing diet, activity, and sleep. The pharmacologic optimization, again, with our membrane stabilizers, our low-dose antidepressants. Interestingly enough, what I found is oftentimes with chronic pain patients, weaning of opioids, benzos, or cannabinoids can also be beneficial. If patients are on even low-dose, medium-dose, high doses of these, and they're still suffering, they're probably not working. Try weaning these off, seeing how they do with that. Again, there's a very small role for interventional pain procedures. Many of you may have had the experience of sending someone to pain management, the patient coming back with a note saying, there's no injection that can help them. Injections have a place, but I wouldn't say it's the only place for pain management. But again, for the right patient, interventions can be beneficial. Same thing with surgery. In the absence of neurologic compromise, again, unrelenting pain, weakness, surgery may be not the best option, but it is an option. So we talked about the biomedical, briefly the psychological aspects. We have maladaptive thoughts, psychological distress, maladaptive behaviors. Think of this as a three-legged stool. If we can just address one of these aspects, we can help patients with the pain and the disability it maintains. So classic examples of this is early on, patients think, there's something really wrong with me, the docs aren't figuring out what's going on. This leads to a lot of anxiety, which could subsequently lead to catastrophization. When patients catastrophize, again, they're messaging, calling the office all the time. What's wrong? You have to do something. Please help me. Again, over time, these maladaptive thoughts could become, I'll never live the life I want. I'm not a good husband. I'm not a good wife. It leads to depression, leads to a lot of the time on the couch, not doing things. Again, so it's a cycle that continues and continues. So if there was some way we could address any one of these aspects, we can help patients with their suffering. And interestingly enough, there is. So cognitive behavioral therapy, it's a sort of 800-pound gorilla when it comes to pain and suffering, is a great resource. If you have pain psychologists you work with, excellent. If you don't, reach out. Most of them will see patients virtually as well. I have a number of patients in New York State who see some therapists in Buffalo, though they live in New York City. So again, if pain psychologists can see your patients virtually, excellent. Emotion-focused and trauma therapy, also very important. I would argue that this is not addressed enough. Approximately 50% of the patients I see in my clinic have significant trauma history. That's a staggering number when you think about it. And so what we found over time is, and again, all of you know this, pain and emotion are processed in the same area of the brain. They're essentially two sides of the coin. You can't possibly expect chronic pain to get better without addressing any significant trauma or mood issues, and vice versa. And so identifying that and treating that can also be beneficial. And then social determinants of health. Again, this is something I learned very little of in medical school, but again, as a practicing clinician, it was very important. I'd make a plan with a patient, I'd see him a couple months later, and they'd say, I'm worse. And I'd say, well, what about the plan? Well, doc, I don't have transportation to the physical therapist, or, my insurance doesn't cover this therapy. Or, I can't do the classes at night. I have to get in line to get into the shelter so I have someplace to sleep overnight. So asking about these questions, identifying them, and providing treatment also very important. Okay, so that's just a quick overview for those of you who may not have had any pain education. Let's go through some cases and some little pearls, if you will. So, mysterious case of weakness. 34-year-old female comes in, complains of numbness, weakness in the arms and hands. She's had pain since she was a child, but told it was growing pains. A few years after her pain started, she had migraines, developed IBS, but overall learned to cope with the pain, learned to function, became a dental hygienist. But 2 years ago, she was involved in a significant motor vehicle accident. Since that time, she has pain in multiple areas. Labs, EMG, MRI, all unremarkable. And she was told multiple times, there's nothing wrong with you. However, she's sitting in front of you crying, saying, but then why can't I use my hands? Why can't I go back to work? Why can't I lift up my kids if there's nothing wrong? So she eventually also mentions, again, she's always tired. She loved to garden, but after 30 minutes, she pays for it. She's in bed for 1 or 2 days. She's so tired. No matter how tired she is, her sleep is poor and she wakes up tired as well, whether it's 1 hour or 12 hours. And she notes she's having more and more difficulty remembering things, and that's also getting worse. In terms of prior treatments, she's tried physical therapy, but she says it's made her pain worse. She's tried a lot of meds, but she's sort of allergic to everything, or they don't work well with her. And again, just briefly, you ask her about gabapentin. It caused a rash. Duloxetine made her feel strange. Pregabalin was discontinued very quickly after 4 weeks. No reason given. And so, you're the 5th doctor I've seen about this. Other docs, they're not listening. They're missing something. Help me. Let's, spoiler alert, this is fibromyalgia. Let's talk about fibromyalgia really quick. 4 pillars. In med school, one of my philosophy professors in med school used to repeat the same thing over and over. And at first it was sort of insulting, but over time I realized he was spot on. He used to say, physicians aren't especially bright. They're just really good at pattern recognition. And I was like, what is he talking about? And he's like, your clinical training, you see something once, and then you sort of put the pattern together, and no matter where you see the patient in the presentation, again, you have it. And so he's like, you guys take it for granted because you're good at it. Most people can't do that. And so when I work with the trainees, I tell them, look for these 4 things. And if you see these, ask about the others. So fibromyalgia is widespread pain, fatigue, poor sleep, and cognitive dysfunction, or patients describe it sort of a brain fog of sorts. And again, these symptoms hold up a roof of varying symptoms, which can also make these patients seem unusually complicated when they tell you what's going on. So what is fibromyalgia? First and foremost, it's real. It's about 3% of the population. I would argue it's much higher. I would argue it's actually not identified early enough or at all. Female to male prevalence 3 to 1. Peak prevalence somewhere in the 5th, 6th decade of life. In genetics, there is a genetic component, 13.6 times more likely to develop fibromyalgia if you have a first-degree family relative. It's not a diagnosis of exclusion. This is something you can diagnose on an initial visit. And interestingly enough, it can coexist with other rheumatologic conditions. This is a fun little debate I have with my colleagues at the clinic in rheumatology. If you place a consult to rheumatology for fibromyalgia, they'll send the patient to me saying, there's nothing we can do. Interestingly enough, there's no other specialty of medicine that has fibromyalgia at such a high co-prevalence. It's almost 50% of patients with rheumatologic conditions have fibro. So I find it odd that they don't want to see these patients, but I will explain why they do that shortly. So pathophysiology of fibro. Over time, we're learning more and more about it. So it is classic nosoplastic pain. There's 2 things going on with fibromyalgia. There's increased CNS pain processing. When you look at the level of the dorsal horn, there was a CSF study done a number of years ago. Substance P was found at 450 times higher than normal in these patients. There's also decreased pain modulation, lower levels of serotonin or norepinephrine in the dorsal horn. And so this combination of increased pain signaling, decreased modulation can very well explain a lot of the symptoms the patients are having. But there's also a component of environment, whether it's childhood stressors, trauma, physical strain, emotional, social stressors, which you may want to identify. Oftentimes patients can cope with a lot of these things well, but there's a stressor and then the symptoms become much more prevalent. The American College of Rheumatology has a modified criteria for diagnosis, excellent sensitivity and specificity. Very simple to do. It takes about 30 seconds to a minute. It's a sheet of paper you can hand to the patient. I apologize, this did not come out well, but I think the point here is the first criteria is pain in multiple areas. So the patient basically checks off where they've had pain roughly over the last week. And then on the backside of that form is the symptom severity scale. They're asking three things: fatigue, waking unrefreshed, and cognitive symptoms on a scale of none to severe. And based on the scoring of this, you can say with a fair amount of certainty whether or not the patient has fibromyalgia. Oftentimes patients come in and say, it's not real. Someone diagnosed with this, they essentially have given up. They just don't want to believe it's there. And so on the third page of this questionnaire, there's a series of those symptoms. Remember how I said it's 4 main pillars holding up a lot of symptoms? I will sometimes read these symptoms off to patients and say, at the end, tell me how many of these you have. And oftentimes they're amazed, like, Doc, how do you know that? And I explain, fibromyalgia is real. It's very well described, and these are common symptoms. But these aren't the only symptoms. It's a second page here I had. And again, I tell them these symptoms are fibromyalgia because oftentimes you get these symptoms worked up, the workup's negative, you're looking at the doc's looking at you, and you're saying, I'm not making this up, but the doc thinks maybe you are because everything keeps coming back normal. Rest assured, this is fibromyalgia. The presentation, again, it's a spectrum on the 4 pillars. I've missed a diagnosis multiple times because patients don't have any brain fog, for instance, but they have severe pain, severe fatigue. But again, in general, widespread musculoskeletal pain is the most common symptom. Oftentimes, I found patients will sometimes only focus on what hurts the most. And sometimes I'll ask, does anything else hurt? And they'll be like, oh yeah, everything else hurts, but it's really my low back I want to talk to you about today. So that's something else to look for. Fatigue, poor sleep, concentration may come up as well. And so the reason I brought this up is, again, 30% of the time patients present with paresthesias of the extremities. You do a complete workup, nothing's showing up. Very common, and I'll oftentimes have patients message me, hey, I can't feel my arms or legs or something's weak, what's going on? And I ask, did it get better? Has this happened to you before? But more often than not, it may be a common symptom of fibromyalgia. Interestingly enough, fibromyalgia is seemingly rare as it is. I see it coexists with POTS quite frequently, hypermobility, as well as mast cell activation. So if I have a suspicion for fibromyalgia, I'll also ask patients about whether they've ever had these diagnoses or they have any of the symptoms to get them also worked up. Treatments, optimization of self-care. And so this is one of the reasons why my colleagues in rheumatology won't necessarily see the patients. The most definitive and best treatments are self-care, diet, activity, and sleep. That's something patients can do on their own, doesn't necessarily need a physician evaluation for. If you want to go down the route of medications, we have pregabalin, duloxetine, milnacipran. Again, they all work roughly in about 30 to 35% of patients. And so if patients want to use these, I let them know and set expectations that statistically, these will not work for you, but happy to try. And if they do provide any benefit, that's fantastic. But oftentimes after months, titrating up, patients are very frustrated. Doc, I'm on this medication multiple times a day, it's still not doing anything. Statistically, it probably won't do anything. Behavioral health, very important to get involved in early, again, addressing the psychosocial aspects and the suffering associated with the pain. And ultimately, a plan. That's what I found the majority of patients really appreciate. Here are the next steps. Even if, again, if it's just self-care, here's a referral to a physical therapist, here's a referral to a nutritionist, here's a sleep medicine referral if needed. They just like to know there's a plan in place, that something's being done, because oftentimes they're being told nothing's wrong, and they leave without a plan. So I've made the mistake multiple times of diagnosing someone with fibromyalgia. In fact, they later come up with a diagnosis of a functional neurologic disorder. And so I have my trainees ask as well, any seizure-like activity, any issues with movement, speech, better with distraction, based on where the presentation is. Again, I've had a number of patients initially say, well, this seems like fibro, but over time they develop these other symptoms and have a functional neurologic disorder. So that's one of the things I keep in mind. Oddly, if you see enough fibromyalgia, I can almost tell the patients who have functional neurologic disorder, they just present differently. I'm sorry, that's not evidence-based, but I've seen it enough. There's just something in the back of my head saying, this doesn't present like the other patients. And so far, it's sort of held true over time. So, but something to keep in mind. Post-COVID syndrome. This is something I also debate with my rheumatologic colleagues as well. I suspect post-COVID syndrome is COVID-induced fibromyalgia. The symptoms are bizarrely similar. There's a huge amount of overlap. And oftentimes, again, I tell my trainees, just ask if the patient's symptoms developed after COVID. If not, I will guarantee you'll come back and tell me the patient has fibromyalgia. Now, whether or not this is true or not, unknown, but in terms of diagnostic and diagnostic reasons, I just ask, have you had COVID? Did the symptoms start afterwards? But the treatments are essentially the same. Self-assessment question 1. Fibromyalgia is classified as which type of pain? A, nociceptive, B, neuropathic, C, nociplastic, or D, psychogenic? All right, let's see what we got. Nociplastic. And so again, as I mentioned before, nociplastic recently advanced as a third classification to pain to distinguish it from nociceptive, which is classically inflammatory, and neuropathic, which is indicative of nerve damage. Thought to be a combination of two things: increased CNS sensory signaling coupled with decreased pain modulation. Series of symptoms include pain, fatigue, poor sleep, memory issues. This type is seen most often with fibromyalgia. But again, various other types of central conditions can also present as nociplastic. Complex regional pain syndrome. So 54-year-old male comes in with painful feet. Onset was a few months ago, rather insidiously, and there's sort of these episodes he has where the pain comes on, feet get red, hot, incredibly painful. Only relieving factor is ice baths for his feet. So PCP diagnoses him with CRPS and wants further evaluation and treatment for the CRPS. So CRPS, it's a clinical diagnosis. History and physical key is very, very important. Symptoms develop usually after an injury to the affected limb. It could be a very innocuous injury, or it could be something more serious. And the symptoms are completely out of proportion with the inciting event. The number of times patients have said, well, I just sort of stubbed my toe on something, or I brushed my arm against the door, and now I've developed this. It's quite remarkable. Symptoms involve a region, and we use the Budapest criteria to make the diagnosis. So first criteria, continuing pain, which is disproportionate to the inciting event. I bring this up because oftentimes I'll have patients come in and say, you know, I have this hand pain, and I'll ask the history, and they're like, well, yeah, I had carpal tunnel surgery, got infected, I had a washout, I had a number of surgeries, and 10, 12 surgeries later, they're like, yeah, now I have CRPS. It's like, well, in fact, it could have been any one of the surgeries, any one of the complications that could be causing your pain. So that's the one thing to keep in mind. What was the event that caused this? Patients usually report one symptom in 4 categories. Again, sensory, motor, vasomotor, or pseudomotor. Anecdotally, I found this to be less useful over time because oftentimes patients come in with the diagnosis, or they Google the diagnosis, and they'll say, oh, well, look, my hand is weak, or look at the color changes between my extremities. They're very specific, and they sort of convince themselves they have this. So this is offset with what we see. And so we want to verify that there are sensory changes, motor trophic changes, vasomotor, and pseudomotor changes as well. One thing to keep in mind, CRPS, again, is a spectrum disorder. So if they've gone through intensive physical therapy, had different treatments, maybe the symptoms are milder than when they initially presented. Or if it's been a couple months, they have pictures of, this is what happened when it first started. And maybe it's not consistent when you see them. But more often than not, the symptoms should more or less be there if it's not well treated or uncontrolled. And again, just going back to this is the final criteria. There's no other diagnosis that better explains the signs and symptoms. So diagnostic aids, can you use bone scan, thermography, EMG? Absolutely, absolutely. But the vast majority of time between the history and physical exam, you can definitely make the diagnosis of CRPS. A couple things to keep in mind. The vast majority of time you see CRPS as soon as you walk into the room. When it's severe, uncontrolled, if the patient's sort of pacing back and forth and they're on their phone and you're wondering what's affected, it's probably not CRPS. Again, is a spectrum. I've seen occasionally patients have come in after very intensive therapy and they're in remission. But if they're saying the symptoms started last week, it's probably not CRPS, spectrum disorder. The definitive treatment is movement, and that's what I explain to patients as well. The medications, interventions, anything we do for you is to decrease the pain so you can move more. Movement is key. Patients that I have with long-term refractory CRPS that have not responded to anything will tell me, we know the pain is good because we know that it's a treatment. That's the only thing we know. And so when we move the affected extremity, the pain is actually good because we're treating the area. And again, oftentimes confused with post-traumatic neuralgia. If they've had surgery or multiple surgeries in an area, post-traumatic neuralgia can present very similarly to CRPS. But again, as I mentioned, there can't be a better diagnosis or another inciting cause to make the diagnosis of CRPS. So in the patient we just described earlier, it's actually erythromelalgia. And again, for those of you who are fans of Latin, red limb pain. Erythromelalgia can also affect the face. Classically, male to female ratio of 3:2. Sixth decade of life is when it most commonly presents. And it can be idiopathic or genetic. The exacerbating factors time and time again could be heat, exercise, or stress. And again, over time, I've seen patients who can't even walk to the mailbox because if any sun hits them, again, the affected extremity will get very red, very painful. And relieving, interestingly enough, is cold. And so one of the things that gets a lot of patients referred over to me is patients will use ice baths of water, especially if it affects the feet. Middle of the night, they'll put their feet in the ice bath. And over time, they can develop frostbite. And so the emergency department is actually my number one refer of erythromelalgia because patients develop frostbite and the ED physician's wondering, well, what were you doing putting your feet in an ice bath in the middle of December? They explain, well, I have this red painful condition. No one knows what's going on. And so very, very classic for this. Treatments for erythromelalgia. We have our classic anticonvulsants, antidepressants, topicals, lidocaine infusions, identifying and treating any of the secondary causes. Cooling is acceptable, not necessarily with ice. And again, pain psychology, and that becomes all the more important if patients are refractory to these other treatments. So question 2. Complex regional pain syndrome, CRPS, exhibits all of the following except A, allodynia, B, skin color changes, C, improvement with cold, or D, edema and swelling. All right, good. The majority of you pass. C, improvement with cold. And so that is another way, again, if patients come in, they say it gets better with cold, I sort of shift my thinking from CRPS to erythromelalgia. So again, CRPS, painful condition that affects the limbs, precipitate through an innocuous injury or direct nerve damage. The diagnosis is made with the Budapest criteria, and the criteria include reported symptoms as well as what you observe. and these consist of allodynia, hyperalgesia, motor, vasomotor, and pseudomotor impairments. There is no relationship between ambient or applied temperature and CRPS. Oftentimes, I will be referred patients, again, with functional neurologic disorder, Parkinson's, MS, post-stroke pain, or dementia. And I list these as formidable opponents because in my 15 years of practice, oftentimes, if the patient is coming to me after having tried treatment with their primary care, their neurologist, oftentimes there's nothing I can do for these cases. And so when I see that on my list in the morning, I quickly look to see, who else they've seen. More often than not, they've exhausted all the neuropathic agents. They've tried multiple rounds of physical therapy. And we'll talk about what we can do about this a little bit later. But oftentimes I still offer them, well, let's try meds again if you'd like. Let's try some off-label options. But for the most part, very difficult to treat by the time they get to me. And again, I'd love to hear if any of you have good responses with patients, and maybe again only the refractory ones come to see me. But when I see them on my schedule, it's tricky, very, very tricky. Trigeminal neuralgia pearls, again, one of the things to keep in mind if patients don't respond to medications, interventional blocks, stellate ganglion blocks, SPG blocks, trigeminal nerve blocks. Again, if there's an interventional physician you work with, they can try these. We recently recruited an interventional physician who does a lot of head and neck blocks. And again, as the patient is started on a medication, he can do a block in office, gives the patient almost immediate relief the majority of the time, and allows the medication to get up to the concentration where it will help out patients. But again, if they've been refractory to medication, the blocks are still an option. Diabetic peripheral neuropathy. Again, we have our pregabalin, duloxetine, tapentadol. Recently, spinal cord stimulation has been approved for diabetic peripheral neuropathy. The randomized controlled trials show good effect at 6 months. Observational studies at 5 years show benefit. The one thing to keep in mind with spinal cord stimulation is just setting expectations. It doesn't work for everyone, and the degree of relief over time should be somewhere between 30 to 50%. Oftentimes, patients will do a trial, and for reasons I don't understand, the trial provides excellent relief, sometimes 80 to 100% relief. The patient thinks, yes, this will be my new normal. They get it implanted. A couple months later, they come back and say, I want this out. It's not working. And I ask, well, what do you mean it's not working? It's only providing 30% relief. That's basically where it settles down to. So helping patients understand this is a form of pain management, but it doesn't take away pain. But it is a good option if other things have failed. Masqueraders. These I see or think of more frequently. Oftentimes by the time patients are referred to me, conventional workup has been done. But again, cervical radicular symptoms with no objective findings, or they've had cervical epidural, sometimes even surgery. Consider thoracic outlet syndrome. I found that to sort of hide in plain sight, but oftentimes it doesn't come to mind. And then for lumbar radicular symptoms, again, no objective findings. Patients have had multiple epidurals, medial branch blocks, even surgery. Consider piriformis syndrome. These are two that they're not common, but again, the little telltale signs is you're looking at the imaging, there's nothing there, or they haven't responded to other things. These may be front and center. So remember those tough cases, right? The post-stroke pain, and MS, and what do you do for incurable and untreatable conditions? This is the question I get asked quite commonly. And I think back to little fun fact, actually. It's probably not fun for any of you. Before I became a physician, I was a firefighter. And before we went to really bad scenes, our chief would always scream before we got out of the truck, remember your training. And I keep that in mind because sometimes when you're in a stressful situation, you may get panicked. But again, if you remember what you were trained in, more often than not, you make it out of the burning building. And so all of us have learned very early on what we need to help, at least temporarily, a lot of these patients with incurable and untreatable conditions. Listen, this is arguably the most important thing I do. And for the majority of patients, sometimes the only thing I'm able to do. They feel heard, their suffering is communicated and they leave feeling better. And so that is very, very important. Again, we learned it early on in our medical training. For any number of reasons, it's a little bit more difficult to do that based on how many patients we need to see in a day, but very, very important. The other thing is, again, hope. Again, I'll sit down, we'll talk about any possible clinical trials, we'll talk about other medications coming down the pipeline, and that can also be very, very helpful for patients. And so listening and hope, again, no one needs to train us in this. You didn't need a rotation in med school for it, and all of us can do it. And again, this is what I do for almost all my patients, and they are very grateful for these two simple things. So ultimately, the biopsychosocial model allows for optimal treatment of all aspects of pain. Listening, setting expectations, also very important when you see a patient longitudinally. And again, I hope one of the things I sort of got across is there's significant overlap in symptoms. Symptoms for different disease states can sometimes be confused. And so, again, if you have that broad differential, you're more likely to come up with a diagnosis and get the treatment the patient deserves. Line of references. Got a couple minutes for questions. Is there anything I can answer? Yes, that is part of the suffering component. More often than not, it's manifesting their frustration because there's something wrong with them. It's impairing their quality of life, their job, their family. They suspect there's something seriously wrong, and every time they see a medical provider, because of the constraints of modern medicine, it's like, well, you know, your 10 minutes are up. I got to get to the next room, and they haven't even told you. And so that frustration builds and builds and builds. And sometimes when patients see me, anecdotally, just 2 days ago when I was seeing patients, one patient said I was the 30th physician they've seen for this, and another patient said I was the 24th physician they've seen for this. And they came in very angry. And what I found is the anger is not directed toward me. It's directed toward the system, past providers. And so one of the things I teach my trainees, and again, I apologize, maybe all of you do not have this luxury. I have a little bit more time with patients. When they come in, I was like, hi, I'm Dr. Tankha. Tell me what's going on. And they say, well, what do you mean? Like, I was like, just talk till you're done. And I listen and I type. Sometimes it could be a minute. Sometimes it could be 45 minutes, and I'm just typing, and it's just everything. Once all of that comes out, the patients are much better. Again, that listening component. Again, is that necessarily practical for everyone? No. But again, the more they feel unheard, the worse the frustration. And again, mood and pain process in the same area of the brain. That frustration makes their pain worse, which makes their frustration worse, and it's just this cycle. So while a number of graduating residents and fellows say, hey, doc, this is great. How can I integrate this? I first ask, how much time do you have for like newer follow-up patients? And again, worst case scenario, if you don't have the time, that's where a pain psychologist comes in. More often than not, they have a good chunk of time to listen, let the patient get everything they need out, and that can be beneficial as well. Yeah. Yes. 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 The question is, patients, when they get referred, are on opioids. The PCP may not want to continue them. What are you supposed to do? Again, not always the best conversation. More often than not, I tell patients, we're not going to make any changes today, but in my professional opinion, which is why you're here, these are probably not helping you. And so we have to make the decision of how we take you off these medication. We'll be slowly, we'll take everything into consideration, but ultimately, again, if they were helping, and sometimes I pose this to the patient or the family member, if these medications were helping, what are you doing sitting across from me right now? Why do you need my expertise? Why do you drive 5 hours to see me, right? More often they're not helping. And if you have enough time to go over the evidence of opioids, they're probably making things worse. They can worsen nosoplastic pain. And so helping patients understand that's helpful. But yeah, I completely understand the frustration of, what are you doing here today? Oh, you're supposed to refill this prescription? And you look at it, you're like, no, I'm not. Again, just sitting down, explaining can be helpful.
You got time? Okay. So how does one tell the difference between fibromyalgia and somebody who has depression, anxiety, who doesn't sleep well, has generalized pain? And is it, at least in the beginning, is it really important to know that difference, because the therapies often are very similar? Medication, exercise, counseling. But is there how is that Budapest? No, that was for CR. The fibromyalgia criteria. How is that different than people who are depressed and anxious having all the other symptoms?
Great question. I'll try to answer this quickly because Dr. Barnett has an excellent talk, and I don't want to cut into his time. So oftentimes I explain to patients that you actually don't have 12 different things going on. It's probably just one, right? The simplest answer is usually the correct one. And so under the heading of fibromyalgia, they can have depression, they can have anxiety, poor sleep. And so I say it's actually a symptom of that underlying condition. So giving them that questionnaire. Now, if they come back with the questionnaire and that only one part of their body hurts, and there's no brain fog, and they're not tired, but they don't sleep well, they don't make the criteria, then maybe oddly they have, 7 different random symptoms. But more often than not, it's actually just a common symptom of fibromyalgia. And as you see it more and more often, it becomes readily apparent that fibro is very common, and as are the symptoms. Yeah, my pleasure.
All right, thank you very much. And our next speaker is another non-neurologist.